Folks, we'll get started in just 1 minute. Hello, everyone, and welcome to The Time is Now, Modernizing Care Through Remote Patient Monitoring. My name is Chris Adamick. I serve as the Executive Director of the Alliance for Connected Care, and I'll be moderating the conversation today. First, a couple of housekeeping items. This webinar is being recorded and will be posted on the Alliance for Connected Care's website. Also, I want to encourage all of you to please submit any questions in the Q&A function. We will be monitoring questions throughout the webinar, and we have reserved time for Q&A at the end of this presentation. First, I want to say a little bit about the Alliance for Connected Care. We are an advocacy coalition that has worked for more than a decade to improve access to telemedicine and remote patient monitoring. Our members are leading healthcare and technology organizations from across the spectrum, representing health systems, payers, technology innovators, patient and provider groups, including many types of specialty and patient advocacy groups who wish to better utilize the opportunities created by virtual care. Please reach out if you're interested in joining. Before we get started today, I want to provide a little bit of context for this conversation. The current administration has laid out clear goals for the greater use of tech-enabled care to overcome workforce challenges, to improve efficiency, and to improve outcomes. There's similar interest from Congress. However, this work is not entirely new. In 2019, the first Trump administration unbundled remote physiologic monitoring and catalyzed expansion of this new type of care. Not to give away the plot of our webinar today, but it's been hugely successful. RPM has shown robust adoption and strong clinical and cost outcomes. The time to double down on this success is now. Looking forward, I also think it's important for us to recognize that our success with RPM is the proof of concept foundation from which the future of tech-enabled care is emerging. Today, we're going to talk about the health challenges we face as a nation, the progress we've come to achieve with RPM, and the future of these services, which will come to transform our healthcare system. With that, I'm going to turn to our introductory remarks from Senator Marsha Blackburn, who unfortunately was unable to be here in person, but did share a recording about RPM and her recent legislative leadership on this front. Thank you.
Thank you so much for the work that you are doing. We have worked extensively to make remote monitoring services for healthcare patients available, and we know what a significant tool it is, especially for those with chronic conditions. And we know how effective it is when it comes to following issues with hypertension and blood pressure and weight. So yes, keep up the great work on that. We are doing our part to try to help you. The Remote Patient Monitoring Access Act. Now, this is a piece of legislation I have. I know you support it. I'm grateful for that support. And as you know, it will make certain that that reimbursement rate is there for these remote services, especially for those in rural and underserved areas. We know this makes a difference. We've recently seen a study that shows for hypertension, diabetes, and heart patients that it generates a savings of about $1,300 per patient per year because you are constantly monitoring and following the needs of these patients. Their outcomes are better, they're staying out of the hospital, and their lives are more productive. So thank you. Keep up the great work. Hopefully we can get my bill passed soon.
Chris, you've muted yourself.
Of course. Thank you so much. I'm pleased to introduce our panelists today. Dr. Richard Kovacs is the current Chief Medical Officer and past President of the American College of Cardiology. In his role, he counsels ACC staff on emerging clinical issues, helps them assess complex medical and scientific data, and also serves as a professor of cardiology at Indiana University School of Medicine, where he served as the cardiology service line leader of IU Health Physicians as well. He's also served as the clinical director of the Granite Institute of Cardiology. Next, we have Dr. Eve Cunningham, the Chief Medical Officer for Cadence. Dr. Cunningham, Cadence is a delivery system that supports health systems, clinicians, and patients in delivering care beyond the four walls of a hospital or clinic. Dr. Cunningham has spent the last 20 years deploying transformational health system programs at scale, leading large multidisciplinary medical groups and integrating AI into clinical care at some of the largest nonprofit health systems in the country. She's a board-certified OBGYN and a leader in virtual care, clinical AI, and clinician burnout. Dr. Cunningham most recently served as Group Vice President, Chief of Virtual Care and of Digital Health at Providence, where she led enterprise-wide transformation initiatives such as inpatient telehealth, remote patient monitoring, virtual nursing, and hospital at home. She also co-founded MedPearl, an AI-assisted clinician decision support platform. Last, we have Dr. Nathan Starr, who's Medical Director, Hospital Level Care at Home and House Calls, Medical Director, Telehospitalist Program for Intermountain Health, a not-for-profit integrated health delivery system headquartered in Salt Lake City, Utah. Dr. Starr is a nationally recognized expert in transforming healthcare by using evidence-based practices and leveraging health technology to deliver high-quality health outcomes. The Intermountain Health and Castell Hospital Level Care at Home program is in a growth phase to support current, future hospital, patient, and community needs. Dr. Starr attended medical school at Kirksville College of Osteopathic Medicine in Missouri, and then returned to Salt Lake City to complete a residency in internal medicine at the University of Utah. With this, I'm going to turn it over to Dr. Kovacs.
Thanks, Chris. And can I have my first slide, please? So as mentioned, I'm a practicing cardiologist and also serve on our National Specialty Society. And cardiology is a good specialty to tee up this topic of remote patient monitoring for a lot of reasons. One is to celebrate the successes that we've already had, but also to help address what I've typified as a perfect storm. We care for both acute and chronic patients in cardiology, and I'm going to try to emphasize that those two efforts are intertwined and in need of help from both ends. In addition, cardiology, like many specialties, but I think uniquely, we are facing an interesting workforce challenge. And we are a very information dependent specialty. We've got a lot of monitors and a lot of patients and a lot of different formats, and we're the benefit of an absolute tsunami of clinical data that's coming in from all the things that we do. Next slide, please. But this is superimposed on this curve. And this are the most recent heart attack and stroke statistics from the American Heart Association, which show that after about a 4-decade decrease in cardiac mortality in the United States for both men and women, we're now seeing a disturbing increase in mortality in the United States. So we've been doing some things right, but now we're starting to have some slippage here in our success at the most important level, and that's how long people are living. Next slide, please. We are also the benefit or the victim of an interesting supply and demand mismatch in that almost half of the US population within the next 10 years is going to have a chronic cardiovascular condition. And they have both acute and chronic needs. Especially demanding is the high readmission rate for heart failure with preserved ejection fraction, which approaches 1 in 5 in a month. This is being combated by an aging workforce. And you can see the statistics, 25% of cardiologists are over the age of 65. So we have an aging cardiology workforce, at least from the physician standpoint, that needs to be addressed in new ways of delivering care. Next slide, please. And we're maldistributed. This recent analysis of the geographic distribution of our specialty shows that almost half of US counties have no cardiologist at all. The vast majority of those counties are rural, and they are the victims of some disparities in the socioeconomic determinants of health. Next slide, please. And as I mentioned, the workforce crisis doesn't just go into the aging of our cardiology workforce, but a lot of other factors as well. And the college has been studying this intensely, and you don't need to know all the details of it. But our trainees train for longer. They hyper specialize. They want to do these very niche sorts of things. We don't have enough APPs. And on the other hand, we have an increasing number of patients. They're increasingly complex. And we have increasing costs and decreasing revenues. So we're getting a very interesting balance. And our own study within our specialty came to an interesting conclusion on the next slide, that we need new models and new tools, and we need to perhaps change the way and the site of our practices for many cases. And I mentioned that, the acute and the chronic care are linked in here. We cannot ignore the fact that that caring for chronic patients and readmissions is going to naturally impair our ability to care for the more complex patients that cardiologists are asked to care for. So there's a clear interplay between these two, and we think we need to do things in new and different ways. Next slide, please. And this is a strong example of maybe we ought not do it how we're doing it now. This is actually hypertension control as a function of personal face-to-face visits with a healthcare provider that was recently published in Journal of Medical Association. And diabolically, these patients, the more they seem to touch us in our clinics, the worse we seem to do in terms of something as fundamental as blood pressure control. So again, we need to rethink how we're doing things. Next slide. And as I mentioned, cardiologists, we like our gizmos and we like monitors, and we've got a lot of them out there. Some simple, as simple as a blood pressure cuff and a way to communicate that information to us. We have these electrocardiograms that people are carrying in their pocket or wearing on their smartwatch and sending us heart rhythms all the time. And then we have increasingly complicated. The device on the right, if you're not familiar with it, that's a CardioMEMS device, which is implanted in the pulmonary arterial circulation to monitor heart failure patients as an outpatient and try to get ahead of situations like incipient heart failure with volume overload. So we go from the very simple to the very complex in terms of our needs for monitoring our patients wherever they are. Next slide, please. Increasingly, we're looking to technical solutions to this, as well as the practical people-based solutions. And the college and the Heart Association are both part of the Cardex and Codex and HL7 Fire Accelerator to try to help us do these things better and faster. Next slide, please. Yeah, there you go. But we've also learned that remote patient monitoring, even in the simplest of cases, is perhaps more complex than we initially thought at first blush, and so we need expert help. So simply moving blood pressures asynchronously from patients to our clinical care teams requires interoperability, it requires coordination of services, and it requires experts at the helm of this. So next slide. I hope I've, in my time, have summarized a case, at least in one specialty. And those of you who are on the call with and have your own specialties, you can probably extrapolate this to what you are doing. So I've sort of given you a litany of our problems, and now I'm going to turn it over to Eve and Nathan to tell us how we solve this. Thanks.
Well, thank you so much. That was a great tee up to talk about Cadence and what we're doing at Cadence. So thank you so much for having me here. And I am really excited to talk to you about what we're doing at Cadence, which I really truly believe, is meeting the need to what Dr. Kovacs is speaking to, and is such an important problem that we're solving, that I felt so passionately about it that not only did I bring Cadence into Providence when I was leading virtual care digital health there, but as they continued to grow and scale, wanted to join this movement of what we're creating and developing as we continue through our scalability process, because it's such an incredible impact that's transformational that we're seeing. I don't think I need to restate the problem here. We know that chronic disease burden is not only expensive in the way that we're managing chronic diseases today, but it's unsustainable. And in addition to that, we also have the workforce challenges and the continuing increasing wave of patients aging into the population every week. I think it's 10,000 patients a week aging into Medicare. So we know we need to do something differently in how we manage these patients. Next slide. So Cadence is unique. So when I was working as the virtual care digital health leader at Providence, we had telehealth, we had hospital at home, we had these remote monitoring programs. We learned a lot during COVID with our COVID home monitoring programs. But what we realized is that to create an affordable, scalable, impactful, and program that also realized cost savings at scale in the organization, we did not have the resources, workforce, or expertise to be able to do that. So what I would see is demos of different remote patient monitoring technologies. They were amazing technologies, but what they were missing was the people aspect. Who is going to consume all of this data? Who is going to consume all this information? And then what are the rules of when you titrate medications or when you respond to different things? How do you optimize the care delivery within that model? And that's really what Cadence does. Cadence is not just a technology platform. We also have a medical group of cardiologists, primary care, nurse practitioners, health coaches, nurses that are extending the care for the health system, primary care physicians, cardiologists, so that in concert together, we're doing this remote care delivery together and in between visits that they have with their regular doctor. And in addition to that, we have a very simple, straightforward approach to engaging with patients. We make it very easy for the patients to enroll in the program, to use very simple, straightforward devices, to communicate in a very simple, straightforward way versus with phone calls and text messages, meeting patients where they are, especially from a tech equity perspective. So on the next slide, I can show you what we've been able to do is partner with many of the largest health systems in the country. We come together with them and we say, hey, you want to provide remote care delivery. We started with hypertension, diabetes, and congestive heart failure. Those are the big three that I had on that first slide. Let's help you extend the care for these patients through a remote patient monitoring program in partnership with your primary care physicians and your cardiologists. And we will extend the care and collaborate with you in a team-based care design. So we're basically almost like a virtual care delivery extension of the health system practices. And together, in concert, we come together with mutually agreed upon clinical protocols to manage these diseases. And then we'll measure the impact and the outcomes. And as you can see here, this to me, can we go back to the slide? Sorry. We are now managing over 50,000 patients. So we're doing something that like nobody's been able to do in the industry because we're at a size and a scale where we're managing 50,000 patients across all of these health systems that we're supporting. And 2/3 of the patients that we're delivering care to are living in rural and underserved areas where they would otherwise get no care. And not only that, we've been able to demonstrate at scale a reduction in admissions and a reduction in total cost of care. So we make it an affordable program that these health systems can stand up on a fee-for-service model, and then they're realizing total cost of care savings on the back end. Next slide. And the reason this is happening is because of the clinical impact. We're able to get our congestive heart failure patients into guideline-directed therapy 3 to 4 times more often than we can do in a traditional care delivery manner. We know that that's associated with reduction in admissions and all-cause mortality. We're seeing improvements in blood pressure control, improvements in diabetes control. We know all of this translates to a reduction in total cost of care downstream. Next slide. And not only that, let's go back to the individual patient stories, okay? What does that mean for an individual patient? Avoiding a CHF exacerbation that results in a hospitalization, avoiding a hypertensive emergency that results in a stroke. Those are impactful things that impact patients on a day-to-day basis. So the stories, the things that we're catching, the things that we're finding through delivering care in this way is super important and impactful at an individual patient level. And I've seen, now that I'm sitting on the other side of this company, because I was the partner on the partner side from a health system perspective. Now I'm able to really see all of the things that are happening on a day-to-day basis. There's countless stories of us catching things that would otherwise not be caught if we didn't have this program. Multiple patients who were bradycardic, for example, and ended up needing some type of an intervention or a pacemaker. We've caught patients who were developing sepsis. We've caught patients who are having active emergencies that needed immediate care, and we're that first line of defense for them because we're available 24/7 for them to get in touch with us. And countless stories of patients also telling us that they feel like this program is giving us peace of mind. We also work very closely with a lot of the caregivers for these patients who say that they feel like this gives an extra layer of security for them. And we're engaging, we do a lot of health coaching, so engaging the patients in their health, understanding their disease, and also reinforcing those care plans around medication adherence or whatever other care plan that the clinicians put in their notes when they're seeing the patients during their every 3-month visits in the clinics. We're able to reinforce those care plans. Next slide. So what does this mean at scale from an industry perspective? You know, this is just high level, some of the math that we could realize with the cost savings that we're seeing with our program if it becomes scaled across the country, if this model of care becomes scaled across the country. And it's incredibly impactful and incredibly important, not only improving patients' lives and the quality of their care, but also realizing impactful care cost savings that we really need to see as we continue to look at sustainability for the health system going into the future. So thank you very much for letting me share our results at Cadence, and I'm going to let the next speaker take over.
Yeah, great. Thanks,
Dr.
Stephen.
Starr. There you go.
Yeah. Appreciate the opportunity to talk a little bit more about the acute side. I think we've had a great introduction of the scope of the problem and what's happening with cardiology. I think is happening across multiple specialties. Especially as you think about access in rural areas. I want to talk a little bit more about what's going on in hospitals and how this can impact. As we think about chronic disease management, how it can impact the hospital side as well. So we can go to the next slide. So many ways, we're facing, like a chronic disease management crisis and acute care crisis. In 2023, hospital care, was a little over 30% of overall healthcare spend, over $4 trillion. Many health systems, Intermountains is part of this now, and communities are facing, significant capacity issues with aging facilities, patients boarding in the emergency department for a prolonged time. Academic and tertiary and quaternary medical centers are full. They're unable to accept transfers. There's delay in access to the appropriate level of care. In addition, construction costs are going crazy. We've been looking at some capital builds, and we're getting quoted $4 to $5 million per bed that if we're going to build. So you start thinking like, oh, we need to build 230 bed units, and all of a sudden you're running $250 to $300 million. It's getting very intense. In terms of how do we manage this rapidly aging population with significant chronic disease burden who will have acute needs in this setting. In addition, we are facing a significant rural health crisis on the hospital side. With many rural facilities closing, there are significant reimbursement issues there. That's a whole other webinar that we could get into. And then, like I mentioned, that access to the appropriate higher level of care is getting limited in many areas. As these facilities are full and we're just running out of space. And I don't think any health system is expecting to build enough beds to manage their growth and capacity issues over the next 10 to 20 to 30 years. It's just simply too expensive. And so we're at a tipping point, where we need, like chronic disease management, really transform how we're looking at acute care and how we treat patients. So we can go on to the next slide. So one thing I've been thinking a lot about is, this chronic disease cycle, where somebody has, they're healthy, then they develop a chronic disease. Eventually they have an exacerbation of that disease. They pursue care. They end up in the emergency department of the hospital. They go through some post-acute care phase, and then hopefully getting back to kind of their chronic disease, and then until eventually they cycle through. Again, if you can go to the next slide. I think what we see happening all the time now is we kind of skip getting back to that healthier phase, and we just end up in these recurrent exacerbations. And the patient's just rapidly cycling through, never really being healthy, putting tremendous strain on the health system as well as that individual patient, who's frequently hospitalized and never at a higher functional status. We can go to the next slide. So if we start to think about remote patient monitoring and really evaluating how we're taking care of these patients, the big goal is, can we prevent these recurrent exacerbations? But I think even a bigger goal is, can we resolve or prevent some of these chronic disease issues, as we appropriately treat patients? Once they have a chronic disease with the right monitoring, can we prevent exacerbations? Or if they're going to have an exacerbation, let's identify that as early as possible so that when they need care, that care can be done in home or the clinic, avoiding the hospital. if they need to go to the hospital and as they transition out, like what's the right process to transition them to get them back, to that highest state of health possible and avoid those recurrent utilizations, and I think remote patient monitoring with different types of technology can impact every single one of these opportunities to keep patients healthier and thereby, reduce the overall, both medical expense and then burden on our health system, with the goal of like we free up those hospital beds for patients that really need care that can only be given in the hospital, and maintain access, throughout our health system in our country that way. So we can go to the next slide. So within Intermountain, we've been doing a lot of work, and this is the best slide I could come up with to show all the different programs we're developing to take care of patients, both with different monitoring programs as well as outside the hospital. And as you can see, it's a huge mess. And I think this is one of the bigger challenges, we're facing as a health system, is there are so many cool tools, there are so many programs, there are so many companies, who are offering solutions. We have our cardiology program working with one vendor on heart failure, and we have pulmonology working with a different vendor, on high risk COPD patients. And they both love the work they're doing. It adds a lot of confusion and uncertainty of who is doing what and how are we taking care of these patients. And so one of the big things we've been working on is how do we consolidate this into a pathway that makes sense. So we can go on to the next slide. So some of the things we've really been thinking about working on. Number one, we have to simplify the process. And I think Dick and Eve both mentioned this. How do we take that massive amount of data flow and actually make it usable, and functional for the right provider to take care of their patient? We've been thinking a lot. How do we identify the right patients? Both patients who are currently have a chronic disease that needs improved management, but also, patients who are at risk. How do we identify them early and mitigate their risk and hopefully prevent the progression to a chronic condition that's much more challenging to manage. Once we've identified these patients, what is the right monitoring? What's the right technology that they need, that will optimize our outcomes? And then always getting back to, what are we actually trying to accomplish with the monitoring? What is our purpose? Whether, it's hypertension with blood pressure control or heart failure, monitoring for exacerbations, but also pushing them towards, optimal goal-directed medical therapy, but keeping that purpose in mind, and then taking that data and ensuring, kind of like what Eve was describing, that we actually have a delivery model for that data. We've been through a couple of iterations of RPM, and what we see has happened over and over, with several programs, is that we collect this data, it's never utilized to actually drive patient outcomes. It just kind of sits in the EHR and some portal. So how are we going to take that data and really ensure that we're optimally managing these patients, and then having the process to continually evaluate each patient for the above. We did a review of one RPM program we had down in Nevada, and found that about 30% of the patients had either passed away, were on hospice, or had never entered data the entire time, that they were supposedly being monitored. So just really making sure that we have the right patients, again, for the right purpose. And then really getting back to, demonstrating that those outcomes, including cost savings. We know that doing RPM is going to add upfront medical expense to these patients. We're going to have to add resources and cost. We know we can save a tremendous amount of money downstream. And so one of the interests we have in Intermountain, it's our CEO's number one priority, is to get as much risk, take on as much risk as we can, so that we have the opportunity to drive these outcomes, keep patients healthy, and have our cost savings and financial sustainability come from that. So really looking, how can we continue to move away from the Medicare fee-for-service model to more cost saving sharing more value type contracts to, reward when we reduce medical expense and keep the patients out of the hospital, that it helps keeps us more sustainable financially. So we can move on to the next slide. So when we think about, opportunities, with those targets, we talked about a few slides ago, we're greatly investing in hospital at home. We are looking at SNF at home, urgent care and ED care at home, expanding specialty care, especially, in our rural areas, through cardiology, oncology, pulmonology, neurology, infectious disease, and several others, as we continue to grow our virtual hospital of taking care to patients in their community and making sure they're getting the appropriate care. We're also really interested in some of these gray area patients where, we see a lot of patients who they're on home health, but they're really pretty complex for home health, but they don't meet criteria to necessarily be hospitalized. But how can we keep those patients healthier and from ending up in the hospital? And then really diving into these high risk populations, like, has been mentioned. We're actually doing a lot of work with our transplant teams right now, and have had success keeping, these really immunocompromised patients out of the hospital, treating them at home, where they're at much lower risk for picking up more infections. We can go to the next slide. One thing that I'm excited about is when we look at the care delivery model we're building for a hospital at home, it actually can cover SNF at home, ED at home. Like the same care delivery model can take care of a wide range of these patient populations, and having the right remote patient monitoring is key, to be successful at this. Go to the next slide. And kind of to end, this is where I'm at. I got this message about 3 weeks ago from Intermountain Health's executive leadership team. They came to me and said, "We want you to grow a hospital at home by 600% in 2 years. You have to succeed." No pressure, but I think this is what a lot of health systems are facing right now, where we, like was mentioned earlier, we cannot continue our current process. Like the health systems are breaking, our employees are burning out, our patients aren't getting the care they need. We need to truly be transformative, and this is the future, and RPM is going to be one of those key tools that allows us to just do things completely differently, and we're really excited to continue this work and for where it's going to lead us. And with that, I'll turn it back over to you, Chris.
Awesome. Thank you so much. I'm going to take the liberty of the first couple Q&A questions, although we've had a few in the chat that I'm excited to get to. I wanted to actually first dig in a little bit deeper. Dr. Starr talked about the challenge of capturing patient data, but then not fully executing on using it in order to make the patient healthier. I know Dr. Cunningham probably has thoughts on how to do that well, and so I wanted to create an opportunity there to chat about it for just a minute.
Yeah, I mean, I think that the core crux of the problem is that, again, you have all this data that you're going to start collecting when you deploy remote patient care and remote patient monitoring, and you need humans, you need people to, like a clinical team, to process it, evaluate it, and then take next actions on it. And that's exactly what we do. And so there is no unused data. All the data that comes in is acted upon. I think one of the things that's been really interesting to see now that I'm on the other side is the way that we split up the work. If you could reimagine how you split up the work that a nurse does, the work that a nurse practitioner does, and the work that a physician does, and reorganize that from a technology perspective to create a very efficient manner of delivering remote care, that's really what we've been able to build at Cadence. So we are able to make create a model in which our team can work extremely efficiently in delivering the care, by using technology and by reorganizing the work and the way the workforce does that work. And everybody's working at top of license. So that's been really fascinating to see and really incredible, because it helps understand how we've been able to get to the scale and the size that we're at today. I also wanted to make one other point. We actually do support the health system so that they can bill successfully in fee for service, and make it affordable to do it in a fee for service model. And then they see savings on the back end with their Medicare shared savings plans or their ACOs. So they're basically like able to sort of live in the 2 feet in different canoes world while we're going through the process of scaling. So yes, the plan is to eventually take on more risk, but if you're a health system that's mostly fee for service, which a lot of health systems are, our program can work to help kind of bring this model of care in an affordable way, and then eventually start to look at how you're going to take on risk and shift your contracts over.
Great. Anything else? Okay, one thing that I wanted to double click on, we've seen a lot of conversation around preventing chronic disease, particularly from the current administration. Obviously, we're talking about managing chronic disease or managing a post-acute condition, but I do think there's an element around patients being able to self-manage when they have their own data. And so I'm curious if you guys have any thoughts on how patients themselves experience an RPM program and kind of how it may help or give them information they wouldn't have otherwise had.
Yeah, and in our experience, I think it can be really transformative when, they're putting forth the effort to actually take some measurements, but then see, what is this, when I don't take my blood pressure medication or I'm not eating right, what does it actually do? What does it do to my blood sugars? Um, because it's working in the home is so insightful, and I think it's one of the biggest advantages of RPM and all of these programs is meeting the patients where they're at and actually understanding, like, what are they really doing? How are they taking their medications? How are they eating? How are they living? And until you understand that whole picture, like, it is so hard to enact many of the changes that you need to, because very often, like, they have real reasons based on their living situations or work schedule that limits their ability to optimally take care of themselves. And so I think it empowers them to understand how that is affecting their health, but also gives the healthcare team the information to, like, how do we actually change your regimen that meets you where you're at and allows you to be successful as an individual.
Yeah, and Chris, I would just, oh, go ahead, Dr. Kovacs.
I was just gonna, I mentioned the the desire of the patients to be able to move stuff in asynchronously. Nathan mentioned, on their time. So many times, we have hospital at home, we have this usual sort of patchwork of these kinds of programs at IU Health, but still the patient satisfaction with being able to get a ECG tracing interpreted so that they know I have atrial fibrillation. I don't need to rush to the emergency department to have my rhythm diagnosed. I can send my blood pressure in when I need to based on my schedule is an enormous patient satisfier. Um, so and it from the health system standpoint, it also locks those patients into the health system. We have competition in the state of Indiana, and it engages those patients in ways that we haven't been capable of before.
Yeah, and I would just comment and piggyback on all these great comments. Like, it's just incredible to see on this end how much I sit in on calls. I look at the stories that are coming in. We're collecting a lot of this data. We do so much education with these patients. We spend so much time just educating them about what it means when the blood pressure reading says whatever, or their heart rate, or giving them lifestyle wellness tips about how different things could affect their vitals or the data that's coming through. And these are the majority of our patients are elderly, right? And they're Medicare age. And so they have they learn and consume information in different ways than maybe a digital native does. And so we're really meeting the patients where they are to educate them, inform them, and engage them more in their care. And I think that's one of our secret sauces, is being able to reinforce that through the remote care model that we have.
Awesome. I'm gonna pick out a question from the chat. Someone asks, and you guys can choose the answer. In your opinion, what work can be done legislatively, both at the state and federal level, to support your work? If you could pick a piece of legislation, what would you like to see move?
Well, I'll start again. So, I mean, the hospital at home waiver extension will be massive. It was so close in December to a full 5-year extension. Currently, it's set to expire, in the end of September, and that's the foundation for most hospital at home programs, and all the reimbursement models. So, getting that security would be huge. Partly, I feel like there's a lot of health systems and technology companies and other folks kind of waiting to feel like, hey, this is a program that's not just going to go away before they really invest. And I feel like innovation is just going to accelerate once we get that security in place.
Yeah, I agree. Hospital at home, it's a barrier without having that extended, it's a barrier for health systems to want to actually invest in standing it up without having a sustainable path to reimbursement. But I really feel very passionately about the Rural Patient Monitoring Access Act that's been submitted with Senators Blackburn, Warner, Kostoff, Pocan, and some of the representatives. It's bipartisan, which is like really important. And the issue that we have at hand is the way the Medicare rates are set up today. They are based on geography, and so rural areas have a disadvantage. And those are the areas that need this type of care the most. So what we need is a parity approach, because remote patient care does not necessarily isn't the teams aren't necessarily living in the states where the care is being delivered. So that whole methodology of how the Medicare rates are created doesn't really apply to what we do. And so if we could get that legislation to go forward, it really is going to unlock and open up that appetite and desire to bring this in even more broadly to more of these underserved and rural areas that desperately need it.
And I'll give a pitch for, we like to advocate at the federal level. I would not ignore what can be done at the state level. I know the newly elected governor of the state of Indiana is very interested in making the state of Indiana, which is not a healthy state, a much healthier state. So we do not have legislative vehicles as yet, but you can betcha that we're going to bring a bunch at the state level to try to leverage what we can do at the state level in a heavily rural state with all of the things that we've been talking about, so that we can more effectively provide access in our rural areas, whether it's with interconnectivity standards, or whether it's broadband availability, or the kinds of things we can do in our state population that can advocate at the state level as well.
Great. Thank you so much. I'm going to throw out another question here. The Alliance has called on CMS to address challenges with RPM reimbursement. Specifically, we've talked about kind of some of the costs associated with maintaining a robust RPM program, including software, technical support, interoperability costs, broadband access, and other kinds of barriers. Can you guys speak a little bit to kind of some of the parts that go into a high quality and well-developed RPM program, and kind of talk about that in the context of a challenging reimbursement requirement? We've had a couple of questions in the chat around like broader cuts to payment and Medicare, and kind of how all these things fit together. So feel free, open questions.
All right, I'll yeah, realizing, the reality is that the pie is so big. So we have to just be honest as we advocate for payments. We have to be realistic about where we might be able to save the system as well. And so I think, tying this, as I mentioned, tying this to the uh, the the acute and the chronic, and and the kinds of longitudinal data that it would take to prove the real bending of the cost curve to CMS, which I know they don't like to be that forward looking. I've talked to my own health system board. So, the halo effect of controlling blood pressure, for example, just that simple effect on all of the other downstream stuff, on heart failure, on stroke, on dementia, on atrial fibrillation. We are going to realize cost savings, but we need to be realistic about what are the trade-offs as well, and make it easier and make it seamless. And I mentioned HL7 and interoperability standards, which have been called for but not enforced at the regulatory level. So we do need to maybe hold a regulator or two's feet to the proverbial fire about what already has been legislated by Congress, and make sure that we're doing the smart things with interoperability standards that would make our lives a little bit easier.
Yeah, and I'll chime in on this. I mean, this is one of the hardest things that to do, is that there's all these different technologies and solutions out there. How do you get the data into the EHR in a meaningful way? How do you pull the data out in a meaningful way, in a way that is also consistent? How do you normalize the data? How do you not overwhelm people with it? And we currently have integrations with multiple EMRs across all of our partners. It is extremely difficult to do, but it is so critical and so important from an adoption perspective to ensure that the clinicians on the health system side have a seamless integrated experience when they're engaging with us and our teams. It can't be in this separate siloed environment, and it can't require those clinicians to have to go outside of their EMR experience because they just are too overwhelmed with all the things that we need to do. One of the things, though, that I think would be helpful from a regulatory perspective, there's requirements that the EHR vendors now have to share data more broadly, be able to like participate in HIEs and things like that. But being able to push things into the EHR is still quite challenging and very customized for every single health system. And it's not a technology problem. There is technology that can do that fairly easily and simply. It's more of guardrails and barriers that some of the EHR vendors place, and some are more friendly to that than others. And so the more that we can innovate in that space, because really we're not going to create a streamlined experience if we don't enable those capabilities more broadly. And I know it's a touchy subject, but it really is something that is getting in the way of us delivering better care. And it's creating inefficiencies, frankly.
Okay. I th I think that's anything else we want to say about interoperability more broadly? Providing that last call. I know we had a few thoughts. One thing I just want to pull out of the chat, we've had a couple of different questions that touched on AI, of course. So I thought I would take this moment to just ask kind of broadly, is there a role for AI in the future of patient monitoring? Kind of what does that look like? Just curious if you guys have thoughts there. I should actually probably just combine this with kind of the broader big picture. I was going to ask you for your crystal ball about what RPM looks like 10 years from now. Is that AI? Is that not AI? Kind of how are you viewing this space moving forward, recognizing that we're almost at time? I'm doing big open questions. You guys take
Well,
it where you feel like it should go.
yeah.
Go ahead, Dr. Starr, you go
Okay.
first.
Thanks. You know, I think we're just in a transformative moment in healthcare, like we've been talking about. Dick said it really well. The pie is only so big for reimbursement right now, and we know that if we continue to operate as we are currently, like we are going to run out of, the Medicare trust fund's going to be in trouble, Medicaid. We're just not going to be able to afford to continue our current system. So looking in the crystal ball, I can definitely envision, with the right monitoring, AI algorithms that for basic heart, blood pressure management, that they can drive a lot of that. They can collect the data, help adjust the medications, start the right medications, and then at some point, get back to a provider. But when we start thinking about workforce limitation and access to healthcare, there's no reason that, for initiating therapies, that with remote patient monitoring and AI supporting a clinician, that it couldn't go a long ways towards that. And then I agree, in terms of just identifying patients who are at risk. It's going to be hugely helpful, and we're starting to see that, and it's coming more and more. But allowing us to target extra resources and to help to the patients that we know that if we don't jump on them now, in 5 to 10 years, we're going to be facing all these chronic diseases that are so expensive to take care of.
I would like to see, as I mentioned, cardiology is a pretty monitor intensive specialty. And I would think one of the primary roles of AI is to help us with the signal to noise ratio, because now we have the potential, people are going to be wearing their potassium sensors. They're going to be, heart rate and pulmonary lung water, you name it, they'll put on their shirt in the morning and they'll be monitored. But I think that where I really hope that AI will go is to improve our signal to noise ratio so that we can truly identify those patients that need the human intervention, the augmented intelligence. And 10 years from now, I do firmly believe that a lot of this will be automated, will be ubiquitous, and will be seamless.
Yeah, and we are actually using some automation and some of these technologies already in our model, and that is what we're using. Obviously, always with a human in the loop component to it. But for example, we have a technology now where we can proactively scrub and review patients' charts preemptively before they maybe have their scheduled visit, for example, with a nurse practitioner, and identify patients who might benefit from a medication titration ahead of time rather than these like every 2 to 3 month visits. It's going and scrubbing through actively all the time and saying, hey, these 25, 30 patients, you should take a look. These might be patients that would benefit from a titration. And based on the algorithms and the care pathways we have, these are 2 or 3 meds that you might want to consider. And it's like reducing, it's creating efficiency. It's helping the clinicians be able to make the decision faster, but also surfacing the patients that are in greatest need and prioritizing them. The same thing happening with our alerts methodology as well. And so we're able to start to use some of this technology to really prioritize the patients with the greatest need that need to be addressed right away, get those patients seen more quickly. And we're actually seeing improvement in our clinical impact, which I've already talked about. We have amazing clinical impact. We're actually seeing that impact grow through these types of transformational technologies. So it's really great to kind of watch it in action as we're making those changes in a scalable way.
Awesome. Final minute. Anything we didn't say that you guys think the audience needs to hear?
I think that that remote patient monitoring, remote patient care is going to become standard of care. So that's my big statement. It is, I am a true believer. That's why I'm doing, I am where I am right now. And I really do think that this is the way forward for us to manage our patient populations better. It's better care.
I totally agree with that.
Dr. Kovacs, did you have one more thing or were you agreeing to?
I was just giving a hearty amen.
Okay, terrific. Well, with that, we're at time. Thank you everybody for joining us. We are going to distribute the remaining questions around to the speakers and I appreciate it if you guys can spend a minute or two answering those. We do have all the people that participated and we can reach back out to them and share some of that. And then we'll obviously be posting this recording on our website. So we'll find that at connectwithcare.org. And thank you, everybody. Thank you to our speakers, and thank you for those great questions in the chat. And we'll loop back and really excited to continue this conversation.
Thank you
everyone.
so much.
Bye.